Good evening, everyone. Welcome you all to this webinar on current approaches and evidence in managing dysphagia following head and neck cancer. I welcome Anirban sir to give a short welcome note.
It is very difficult for me if you would say that give a short welcome note for Arun Balaji exclusively, one of the international legend in the field of cancer, and especially for speech and language pathologists, like in the field of swallowing related to cancer and complete cancer rehabilitation. Because like it is his dedication, his passion, and completely if we look into it, like his skill and his hard work has brought him in this platform today. And Arun is really like, we feel proud when we hear that there is someone as Arun Balaji and doing a great work. And I really don't know how he manages time. Looking at the Elvestone Tata, it's a huge hospital. There is a department previously, I mean, Mrs. Gurmeet used to take care of, and then Arun comes in, and then they have a huge load. With that, they are top of that, he has to go to Navi Mumbai. Top of that, Kolkata. Arun was there for sometimes in Kolkata as well. So I really don't know like how he manages all this, and plus they run courses, and they have to, the main thing is the documentation and the quality service, because the department is there with that is what is very important, so that is what I mean, for each and every patient, whenever they come to Tata, they come with a very high expectation from all the corners, because that is one of the charitable hospital. And for the patient, like ultimate anything goes wrong with oncology or cancer, Tata is the god. Okay, they see only the light to survive by reaching Tata. And I mean, like, so you understand that how much stress always is there on Arun, because like speech was still, Gurpreet was there, like speech was not being entertained in such a way. It was a small department, whatever I knew long time back when madam was there. And then plus what happened is the team which was there was also excellent team, Rajesh Mistry, Mandar Deshpande and all. And the team changes, and rehabilitation also process changes a lot over there. Though they are still involved in something, Mandar Deshpande and all, because they are much more research oriented, Dr. Mandar Deshpande and all. But Arun comes in and makes the whole lot of change. And that's really good thing about him. With a small team, how he does the work and how he is doing the work over there. So, so we are very fortunate to get him. Actually, he was ready whenever we have given him a call. We have asked him, but the problem is with us is we were missing the date due to some not something, and some not something was coming up. I always have a special place for Arun. Not only I know that many of the seniors in the field is really, we are having a special place for Arun in our heart, in our work. And it's a respect, special respect. And I feel that he's a legend. He's a legend. Though he says that no, it's not. But I feel that he's a legend. Like another one, like person coming up is Prasanna Hegde as well. But then Arun's work is Arun's work. It speaks. And when we hear his name in Australia, in New Zealand, in other cities like US, Canada, like even in UK, whenever the laryngectomy is there, and especially even with the transgenders association also, they are also like, he's been spoken with a lot, like he's been praised by a lot of people over there. So WPATH is one of the association, plus laryngology and voice associations. Though in the voice associations, like we have Prakash Bhuminathan, we have Dushali Desai and all, but Arun's is always a specialized work. And it's a specialty, and it's a specialized drawing, you can say. So whatever Arun will speak, it's like a sketch, and it goes straight away into your head, and it remains as a sketch. You don't need to read top of that. Okay, so we are lucky here today that we got him, and I don't want to waste my time. I was just, have been given a task unwantedly at the beginning. I told Susan I will do it at the end because I don't know where to begin to talk about Arun and where to end because there are lots and lots more to speak. So anyway, so I'm really thankful that Arun has come, and I welcome on behalf of the Institute of Helen Keller Institute of Research and Rehabilitation for the Disabled Children, Secunderabad. And this is just a beginning with Arun, and we are planning actually to tap him twice every year. We are planning to tap him twice every year with some topics coming, and I know that Arun will not say us no, and he will also do it. But the thing is, adjusting his time is very difficult. So we will go according to his willingness and his time in future. So it's over to Arun now. Arun, please.
So I'm just giving short instructions to the participants. All the participants must place their mic on mute. Whatever questions or queries you have to place them in the chat box, and they'll be answered after the talk during the question and answer session. And the speaker for today's webinar is Mr. Arun Balaji. He's a section lead at Speech and Swallowing Therapist at Department of Head and Neck Oncology, Tata Memorial Center, Mumbai. So I'll just give a
Hello, madam. Can you all see my screen?
So Mr. Arun,
Yes,
Arun
we all can see.
Has
Yes.
He has completed Bachelor's of Audiology and Speech Language Pathology at Manipal University in 2009. He has completed Masters of Audiology and Speech Language Pathology at Ali Awajang National Institute for Hearing Handicap, Mumbai in 2011. He is certified in Modified Barium Swallow Impairment Profile in 2020. Currently, he is working as a section lead speech and swallowing therapist at Department of Head and Neck Oncology, Tata Memorial Center, Mumbai. Previously, he worked for Tata Medical Center, Kolkata and Mute Hospitals, Chennai. He had several grants awarded and also the international training. He was awarded Sir Ratan Tata Trust Travel Grant for speech and swallowing therapy training in Boston, USA in 2014. He also was awarded the Tata Educational Developmental Trust Grant to undergo postgraduate intensive dysphagia diagnosis and management course led by Professor Maggie Lee Huckabee, Rose Center of Stroke Recovery and Research, University of Canterbury, New Zealand in 2018. He has been invited at international level for different lectures. The first one was laryngectomy rehabilitation in India. It was conducted in London in May 2021. Next is the laryngectomy rehabilitation international perspective done by Royal College of Speech and Language Therapist, CEN, Head Neck Cancer Study Day on 16 November 2021. His achievements in head neck cancer rehabilitation. He has established modern dysphagia rehabilitation services in 3 different oncology hospitals in India. That is at Tata Medical Center, Kolkata, Tata Memorial Hospital, Mumbai, Advanced Center for Treatment, Research and Education Cancer, Navi Mumbai. His special interest is in swallowing evaluation therapy in head neck cancer, surgical voice restoration, total laryngectomy, troubleshooting and valve change, radiation associated dysphagia management, voice and swallowing rehabilitation in total laryngectomy, voice evaluation therapy in head neck cancer, speech and video fluoroscopy in dysphagia evaluation and therapy, teaching and conducting courses on speech and swallowing rehabilitation, to develop and head and neck lymphedema management services, service development, speech and swallowing rehabilitation in oncology, and also to set up an advanced Tata Speech and Swallowing Rehabilitation Research Laboratory at Tata Memorial Center, Mumbai, India. Over to you, sir.
Thank you so much, madam, for this elaborate introduction, and I would like to thank Dr. Anibarandas Gupta sir for giving this opportunity. And today, this is a coincidence of my mentor, guru, not only for me and many other speech language therapists and audiologists, Professor Dr. Rajsek sir birthday. Actually, I'm happy that I could do this lecture on his birthday. It is truly a coincidence, and birthday wishes to you, sir. And one thing we have to understand: teachers used to teach us to grow, but very few teachers will inspire us. Dr. Rajshekhar sir is like inspiration for me, as well as many speech language pathologists in India and even abroad also. I would like to dedicate this lecture to Professor Dr. Rajshekhar sir. And thank you for this opportunity. Today, I will be discussing on current evidence and approaches and dysphagia management in head and neck cancer. When we talk about dysphagia, head and neck cancer, the impact of head and neck cancer is huge. The impact can happen due to tumor or due to cancer or cancer treatment. These are the two impacts. It can be either due to cancer or due to cancer treatment. So when we take head and neck cancer, what are all the impacts that we are going to expect in these patient groups? Definitely breathing issues. Patient can experience breathing issues either before initiation of treatment, that can be due to cancer, or during the treatment, and even after treatment also. And next thing, swallowing, dysphagia. It can be oropharyngeal dysphagia or pharyngeal dysphagia, speech impairment or voice impairment, cosmesis, and hearing. So broadly, we can classify the impact of head and neck cancer into three types. One is surgical related functional challenge. The next is non-surgical related functional challenge, and palliative care in speech and swallowing rehabilitation. So before moving on to the this core dysphagia topic, being a speech and language therapist, we need to understand few things in head and neck cancer. That and as I said, the impacts. This is also one of the impacts. Here you are seeing pictures of the patient who are undergoing radiation therapy and who have completed the treatment also. Patient experiences various challenges, unable to eat, unable to enjoy their food. When they eat drink, they will have a lot of burning sensation in the mouth. And look at this gentleman. He has a lot of mucositis in the oral cavity, as well as you can see the soft palate as well. So next patient, this patient, it's a female patient. Look at this lips, lot of mucositis, and there is a skin reaction. It can happen in the neck also. And look at this gentleman who has who has nasogastric tube during treatment, and see after 2 months after treatment. So patient may have a lot of impact during treatment, post-treatment, and speech language therapists play a critical role in successfully completion of the treatment as well as rehabilitation for these patients. Remember the head and neck cancer. See, majority of our head and neck cancer patients are males. There are female patients who are also having head and neck cancer. What happened? What are the impacts? The impact is not only dysphagia, voice impairments, speech impairments. They have challenges in financial aspects also. If some of our family member who is the breadwinner of the family, if they have challenges and they cannot go for work almost 6 months, definitely they will have challenges in terms of financially. And so the treatment is not a single day. The treatment may happen for, if it is a radiation therapy or only post-surgery radiation therapy, that itself almost 2 to 3 months. If it is only radiation therapy, it can be 6 weeks or 7 weeks. And after that, the rehabilitation have to happen. So the treatment is not very simple. So treatment is going to be a tough task. We as a speech language therapist, we have to explain these things, and we should not make the patient as well as caregiver panic. We should tell these things, and we have to inform the patient that you may experience, and we are going to support during the entire treatment and even post-treatment as well. And one of the challenge the patient are going to experience is lymphedema. Lymphedema is one of the swelling can happen because all the neck nodes may get affected. So our neck fluids will not drain properly. And if you see the head and neck lymphedema, we can broadly classify the head and neck lymphedema into 2 types. Look at this gentleman, same patient. He is the same patient. Look at this gentleman. This external lymphedema. If you see his neck, submental region, he's having soft pitting lymphedema. And internal lymphedema we can visualize only after doing endoscopy. It can be rigid endoscopy or flexible endoscopy. We can see how much is the lymphedema. And when you visualize the lymphedema, we have to ask 2 questions: whether lymphedema is present or absent, yes or no. If it is yes, how much is the severity? That also we have to keep into mind. And see, after almost 1 year after treatment for this gentleman, definitely external lymphedema has settled down very well. And we performed the endoscopy. There is a little reduction in the internal lymphedema. Why I am discussing this edema to you? Because this affects voice as well as swallowing. The research have reported that patients who are having external lymphedema, they have the correlation saying that they have difficulty in eating, drinking, and even speaking as well. So this is one of the important aspects we need to understand in head and neck cancer. And next challenge the patient going to experience is trismus. Trismus is nothing but, trismus is, I'm sorry, just a minute. Trismus is nothing but reduction in jaw opening. And if you see these patients, they are unable to open their mouth very well. It can be due to tumor, or it can be even due to tumor treatment as well. Majorly muscles involved, mouth opening will get affected. This is a very good research by Joe Patterson team from United Kingdom. What they have told is, they have taken a few groups of patients, those who are undergoing non-surgical treatment aspect in majorly laryngeal cancer and hypopharyngeal cancer. So those patients, they were planned for concurrent chemoradiation. So when they used University of Washington quality of life scale, pre-treatment, 3 months treatment, 6 months and 12 months, in every time points, what is the major concern for the patient is swallowing aspect. In 4 time points, all the group of the patient, they said that dysphagia is one of the significant burden for them. So this University of Washington quality of life is one of the patient reported outcome measures. It consists of 12 questions. Each questions ask different things such as pain, appearance, activity, chewing, shoulder dysfunction, how's the taste, saliva, everything. So this published in almost 2011 or 2013, and what important message from this paper is swallowing is one of the major concern for the patient who are undergoing chemoradiation or non-surgical treatment. So the next question come to us is, how are you going to do an evaluation for this group of patient, head and neck cancer? Definitely, we are going to study, we must have studied in our undergraduation program as well as post-graduation program. Definitely, our evaluation should start with the treatment, start with the history of the patient and case review by reviewing the case files, and then evaluate oromotor examination. And one of the very good evaluation what we can perform clinically is water swallow test. Water swallow test is a very good clinical tool we can use in our day-to-day life clinic. We in our hospital we use water swallow test, majorly 100 ml water swallow test. And if you suspect that the patient may be having a severe risk of aspiration or he may not be able to take very well, start with modified water swallow test, or the water swallow screening protocol given by Christian Hay is a very good protocol. She's from German, and they have given a very good method like how we can proceed, like go with 5 ml, 20 ml. If 20 ml is no any issues, repeat the 20 ml and then increase the quantity of water. Why we are going to use water? Water is one of the challenging consistency, and sequential swallow is also one of the very challenging thing. So when the patient fails in a water swallow test, they are high risk for having dysphagia and aspiration risk. Failure in water swallow test, what are all the criteria to fail? One, patient immediately or after taking the water, the patient may have cough or throat clearing, change in voice. These three things we have to keep in mind after doing the water swallow test. And along with that, you can use a 4-finger test as well. These are the clinical dysphagia evaluations, but your evaluation should not end only with clinical dysphagia evaluation, because the challenge in this water swallow test is we cannot identify the pathophysiology of the swallowing. But astute clinicians have to estimate or hypothesize the pathophysiology, and then those patients who are high risk, definitely we have to take for further evaluation to understand the pathophysiology of swallowing as well. So one of the most challenge that we may experience is missing. Sometimes we may miss, not sometimes, many times we may miss silent aspiration in clinical evaluation. Look at this picture. One of our patient has tracheostomy. How are you going to evaluate swallowing in this patient group? We can use either green food dye or blue food dye. Just keep small 50 ml water and pour it 2 or 3 drops of green food dye, either one color, and try to give the patient and see how the patient is swallowing. After swallowing, is he having any cough? If you have any nursing specialty, you can ask the nursing team to suction the tracheostomy tube and see is there any color material is coming out or not. These indicate the silent aspiration. Silent aspiration is nothing but patient, he may be aspirating, that is food or liquid entering into the lungs without any kind of cough or throat clearing or change in voice. So these things we cannot understand only with clinical evaluation. So further evaluation is necessary. This is a very good paper by British Association of Head and Neck Oncologists, published in 2020. So what is the recommendation of British Association of Head and Neck Oncologists. Specialist multidisciplinary team is essential in evaluation and intervention of head and neck oncology. So speech language therapist is essential in head and neck cancer rehabilitation. And look at this protocol, what a speech language therapist should be and what all things are necessary in cancer management. So every patient should have access to speech language therapist. And what they have recommended, video fluoroscopy and fees is mandatory. To have the setup should be mandatory in head and neck cancer center or cancer hospital. So multidisciplinary assessment is essential. Rehabilitation recovery protocols and post rehabilitations, and speech language therapist also should have competency in total laryngectomy rehabilitation. So these are the essential competencies that one speech language therapist should have, those who are working in cancer hospital or those who are getting caseload with head and neck cancer. This is one of the mandatory requirements by British Association of Head and Neck Oncologists, and such a high competence is essential because the patient groups are not very simple. What we are going to expect is a very complex patient, so we need to manage in very cohesive manner as well as multidisciplinary method. So when we think about oral cancer, how are you going to rehabilitate oral cancer? The treatment of oral cancer is definitely surgery. Even it can be early tumor or advanced tumor. So staging will be done by head and neck oncologist. Staging will not be done by any speech language therapist, but being treating head and neck cancer treatment, we need to understand what is mean by staging, what is mean by TNM staging in cancer, that is tumor, node, and metastasis. That we have to keep in mind. If it is T1, N1 means node, it can be right neck node or left neck node can be there. Okay, if it is M1, those patient will have cancer beyond the part, it can be lungs also. So those patients may not be undergoing any curative form of treatment. They may be going for palliative treatment because it is metastasis, it has spread to the other parts of the body. So the first question is whether the patient is undergoing to have a curative treatment or palliative treatment. So even speech language therapist evaluation and intervention also varies based on that. So we need to understand, first of all, head and neck cancer treatment pathway. So oral cancer, generally, they go for surgery, followed by histopathology report, review, and then decision for further treatment such as radiation or adjuvant chemotherapy, adjuvant chemoradiation therapy. So this is a very good research done by Royal Marsden Group. So let us see how they have developed this protocol. Baseline pre-surgical functional evaluation they have recommended. That is a very, very key aspect. We all think, okay, after surgery, patient is not able to eat very well. If you think about the functional orotic scale, his FOS is just 4. That will be that we may say that it is only because of post surgery, but not like that. Not always. All the patient will have a functional orotic scale 7 prior to the surgery, because if it is tongue carcinoma, if the patient is planned for total glossectomy, I don't think so the patient will be having FOS 7. That is one thing which we have to keep in mind. Baseline pre-surgical functional evaluation. Even in our hospital, we are trying to do for many more patients, but it is going to be very challenging because we cannot do all the patients unless until we have sufficient human resource as well as sufficient infrastructure. So that we have to keep in mind before putting into any kind of a protocol. And next thing is, post-operatively, we have to see the patient. We have to tell about what's a patient, like how we do pre-laryngectomy counseling. We have to do pre-oral cancer surgical counseling, what the patient is going to have, how it is going to be impact, and how they can cope up with the post-treatment rehabilitation. That is one of the major things that we have to explain to the patient. And after the surgery, within 3-4 days, we have to see in the ward, and we have to evaluate. We have to do a comprehensive assessment, and whenever possible, definitely we have to think about objective evaluation as well. We should not stop with only clinical evaluation. Definitely we have to think about objective evaluation for the better management of this patient, by explaining the patient that he's safe for swallowing liquids, and we can proceed for soft consistency, etc. So look at this work. This is one of our work. It is results of sequential swallowing assessment in patient undergoing upfront surgery for oral squamous cell carcinoma. It's almost huge number of patient data, and we have taken almost 229 patients. We had 3 time points, that is within 30 days of surgery, and 3 months post surgery, and 1 year post surgery. So what we did is we used clinical swallowing evaluation. We did not, even though we did a video fluoroscopy, almost more than 30% of this group, but we did not put in this paper. We used 100 ml water swallow test, functional oral take scale, and performance statistical for head and neck cancer diet section. What is our conclusion is, swallowing function improved over time, but higher defect with pedicled flap, the outcome is poor at the end of 1 year. Means like patient, those who are undergoing free flap reconstruction, their functional outcome is very good, better than patients undergoing any kind of pedicled flap reconstruction. So what we need to understand is, when they undergo surgery, always we need to have surgery when they remove the tumor, and if it is huge, definitely they have to add some tissue. That is, reconstruction should happen. So reconstruction can be any method. We can do the reconstruction either by hand. They can take the tissue from the hand, tissue from the thigh, or from the bone from the leg. So we can call it as a radial forearm free flap, or anterolateral thigh flap, or a free fibula osteocutaneous flap. So whenever the patient is undergoing surgery, we have to keep in mind, it is not only removal of the tumor, because we have to think about reconstruction also. So those things will have impact in terms of outcome as well. So we just move on to laryngeal cancer as well as hypopharyngeal cancer. So oral cancer, what we saw is, definitely it requires intensive treatment. At the same time, it is not a one-day treatment. Sequential assessment is essential. That is like acute phase as well as long-term phase. And next, moving on to the laryngeal and hypopharyngeal cancer. So when the patient comes with laryngeal cancer or hypopharyngeal cancer, what are we going to do? Definitely oncological workup should be done by a medical team. See, always remember, people will say that we are not having objective evaluation. But what we have to think is, we have to think like a surgeon. Because if a surgeon, if he want to operate a particular person, he will examine, he will ask for any kind of a CT scan or MRI, he will create the roadmap, and he will sketch the roadmap. Okay, here I am going to resect. So then he will go and he will resect and come. We need to have such kind of a mentality, a speech language therapist. We cannot go without any kind of a map. Otherwise, our intervention will not be a successful one. So functional workup by speech language therapist, and we have to do a clinical swallowing evaluation, do water swallow test, see the aspiration risk. And in laryngopharyngeal cancer, our first choice of the objective evaluation is flexible endoscopic evaluation as following. So we do fees examination and see how the patient is swallowing. If the growth, for example, patient may be having growth in severe growth, laryngeal cancer growth, I'll show the images later. Okay. If it is too much of growth, which obscuring the endolarynx, definitely we cannot do the fees examination. And then we have to do a video fluoroscopy. So these two papers are very wonderful paper, and the Heather Stammer paper, and even our paper also. Heather Stammer paper also said that same thing. Functional evaluation and the video for objective evaluation is very, very essential. And based on our evaluation, multidisciplinary tumor board will happen and decision also will be taken. If the functionality is good, he will go for organ preservation, that is chemoradiation. If the functionality is very bad, that patient is not a candidate for organ preservation, then those patients undergo total laryngectomy. So what is the point? Yes, we are not just giving treatment. We speech language therapists also have a role, big role in selection of cancer treatment also. So even though the imaging wise, he is a candidate for organ preservation, but his functionality is very poor, that he or she, the patient, is not a candidate for organ preservation. This is one thing we have to keep in mind. So speech language therapists have a much more role to play in head and neck cancer. So this is our fiber optic endoscopic evaluation following setup. So now, due to this COVID-19 outbreak, since 2 years, we have to use personal protective equipment very effectively, because all these procedures are aerosol generation procedure. So we, as a clinician, we have to be careful. At the same time, we have to be very careful for the patient, because COVID-19 is the transmission is majorly due to aerosol generation. So these things we have to keep in mind. So this is our video fluoroscopy setup. We do our video fluoroscopy service jointly with our interventional radiology and our radiographers. So the paper here, those who are interested in video fluoroscopy, look at this article by Roger Newman. Roger Newman, he did not even write, he has written this journal article. And Roger Newman and Julie Nightingale, both of them has written a fantastic book on video fluoroscopy. If someone wants to be competent in video fluoroscopy, I would recommend them to read that book. It is a very beautiful book. Roger Newman is a speech language therapist, and Julie Nightingale is a radiographer. So you look at the combination. So it is always teamwork. It is not just like who is big or who is lower. So we should not think about all those things. It is because it is the only thing what is our focus should be patient outcome. That is a major thing. So I will like to show a few video fluoroscopies and the fees examinations, and how are we going to interpret those things, and how these objective evaluation are helping our intervention as well. So this is the first video fluoroscopy. This is a normal video fluoroscopy. Look at this video fluoroscopy. This fluoroscopies, we have to do 30 frames per second. This is a normal fluoroscopy. That doesn't mean that this gentleman actually it is a normal. This patient had an esophageal carcinoma. It is a post chemo radiation. I performed this patient almost in 2013. Look at this. Focus on this region. How is laryngeal elevation is happening? How is the epiglottic retroflexion is happening? How bolus propulsion is happening? This is with the larynx, and next we will see this patient also with the larynx only. But this patient do not have any teeth here, and very good, just a little mild residue is there. One second, I will play this video. Fantastic. So these are all normal video fluoroscopy. This patient had a post-cricoid growth. Look at this again. See, look at the epiglottis inversion. That is what we call it as epiglottis inversion. It will protect, and look at the laryngeal elevation also. I'll go to the next slide. If anyone, if you're having any question on this video fluoroscopy, please ask. Okay, these are all very useful for you guys to understand. Next, the same patient, the post-cricoid. This patient, it is when she had a post-cricoid growth, and after this, she underwent chemo radiation. And the same patient developed recurrence and underwent total laryngectomy with free jejunum flap. Look at this video fluoroscopy with magnification. Sometimes, whenever necessary, we may have to magnify, especially in total laryngectomy. Not in other head and neck cancer. Only in total laryngectomy, when needed, we can magnify. We can see the voice processes, and look at this free jejunum. Free jejunum, it is like from stomach, they will take the tissue and do the reconstruction. Look at this patient, same patient. She had a pacemaker also. So see the peristalsis of the free jejunum. It is not like normal tube. It contracts. Okay, it is like spring. So we need to understand why there is a challenge in swallowing. We need to explain the patient very well. We need to counsel the patient very well. See, after total laryngectomy, their life is going to be different, not only in speaking, even as well as swallowing. These two things are very, in total laryngectomy, they are very unique population, unlike other head and neck cancer. So normality is not going to come. Only thing we have to adapt. That is one of the key thing we have to make our patient understand. And especially total laryngectomy patients are very, very cooperative patients. And look at this video fluoroscopy. It is a tongue resection, anterior to the tongue with radial forearm free flap. That is from they have taken for UG students. I would like to explain in a little simple way. FRAFF, that is free radial arm free flap. This tissue they will take from the arm, right arm, okay, or left arm as well. Look at this video fluoroscopy. Immediately after surgery. It is very good. It is 3 weeks after surgery. There is no any aspiration. There is a residue is there, and bolus propulsion is also very good. Once again, I will play this one. Very good. And next, we will see in this total laryngectomy, total glossectomy with the PMMC flap. That is from chest flap. Look at this. The patient is having severe difficulty, and the patient is having multiple swallow. Look at this. Base tongue retraction is very poor, and the epiglottic retroflexion, it's not happening. There is a laryngeal penetration. and even aspiration as well. So the size, location of the tumor, size of the tumor also we need to understand in rehabilitation too. So let us see in fees in post-thyroidectomy. I would like to, if anyone interested in fees in head and neck cancer, this is one of the very good paper written by Michael Dutchman from Canada. It is a very good paper, and if you read, they have used the fees even in oral cancer patient also, and they and how fees is supporting in immediately after surgery and even post radiation. Very good paper. I would recommend everyone to read this paper. Look at these fees. See the secretion before seeing any endoscopic image. Look at this secretion, location of the secretion, color of the secretion, and see the consistency, how it is. See the secretion in the piriform sinus, severe. And look at this gentleman, poor laryngeal elevation, severe residue is happening. He's trying to swallow, not happening. Pulling is happening at the piriform sinus level and aspirated. This is 1 month after total thyroidectomy. This gentleman, he underwent total thyroidectomy at some other hospital and he visited. Now he is doing very well. So after treatment of head and neck cancer, some patient may fail. Even though the cancer, they are rid of cancer, sometimes their function will be very poor. Look at this gentleman. He had a carcinoma of a piriform sinus. This is post chemoradiation, almost 1 year. He was having severe dysphagia, and he was having feeding tube for long duration. In spite of therapy, there is no any improvement. Look at this video fluoroscopy, how he is performing. During swallow aspiration, and see the amount of aspiration, and he coughed after that. It is penetration aspiration scale 7. And remember, when we are giving outcome measurement, it is video fluoroscopy or fees. It is not just saying that yes, presence or absence of aspiration. It is beyond that. It will provide the pathophysiology. We need to understand how the laryngeal elevation is happening, base of trunk retraction is happening, epiglottis inversion, and piriform segment opening, and bolus hold, bolus propulsion, and even swallowing initiation. These so many things are there to analyze this video fluoroscopy and even fees. Look at this, and this is completely a dysfunctional larynx. And we discussed this patient with our head and neck surgical team, and we then felt that this gentleman need total laryngectomy, removal of entire larynx. So for dysfunctional larynx, one of the last option is total laryngectomy. But remember that these decisions have to be taken in a shared manner. So speech language therapist, head and neck team, and even patient, as well as caregiver, everyone should understand what's the need. For example, if you remove the larynx, definitely they cannot speak. Now the patient is speaking. He can communicate well. So we need to ask the patient, what is the priority? That is the most important thing. Some patient will say that I live with voice, I need voice, I have to use my voice. Okay, and I'm okay with the feeding tube for long duration. Some patient may say that no, I'm not very happy. This feeding tube is causing a lot of problem, and I feel like eating. So we have to take patient consideration and caregiver. All those things are very, very essential. It should be an informed decision for the patient, caregiver, as well as the multidisciplinary rehabilitation team and head and neck surgical team. The next patient is a hypopharyngeal cancer. This is a before treatment. And look at this patient, how the patient is having swallowing. This see severe aspiration. There is no any opening. Look at this pharyngoesophageal segment opening. There is no any opening. Hardly you can see opening. Sorry. Yeah. Sorry. Yeah. This severe aspiration. This is also dysfunctional larynx. It's a pre-treatment. We need to understand. And we discussed this patient in a joint clinic, head and neck joint clinic, and then we decided for total laryngectomy with the gastric pull-up. So I'd like to show you one fees, a normal swallow. So look at this. There is no secretion. So when you do the flexible endoscopic evaluation swallowing, always you have to see secretion, how it is happening. Just a minute. Sorry. Look at this fees. This gentleman is a oral carcinoma, a small tongue lesion he was having, and see how he's swallowing. This is a complete, there is no any residue. There is no any residue. There is no residue in the piriform sinus. There is no residue in the vallecula also. Once again, I will play this fees examination. And look at this whiteout. Whiteout, we can. This is the whiteout. When we read in the textbooks or when we read in the fees paper, they will say that whiteout. It is at the height of swallowing. So what happens when hyolaryngeal elevation is happening? So all the muscles will squeeze, and the endoscopy will be come into close contact with the musculatures. So that time we cannot visualize. This is during swallow. So that is one disadvantage in the fees examination. And after that, we can visualize. So this is one disadvantage in fees, but we can infer lot many informations from the fees examination because it has various tasks, that is observation of the structure, and then non-swallowing task, swallowing task. All those features are very, very essential to make an impression from this examination. Next, we will move ahead with the fees. After laryngeal cancer, it is 6 months. I think it is 6 months post-treatment. Look at this patient, carcinoma of larynx, post-chemoradiation, how he is swallowing. Look at this epiglottic inversion. It is fantastic. So when you do a sequential swallow, okay, this is how it is going to be. And you can see there is a difference in the laryngeal anatomy. A bit of edema is there in this patient and this patient. This is a normal, there is no any edema. And this patient, it is having edema. It is a mild laryngeal edema is there. So I hope till now everyone are understanding. If you have any questions, please stop me and you can ask also. Next, we will see one patient. It is the carcinoma unknown primary. Some may be knowing about unknown primary. Some of us do not know what is meant by unknown primary. Unknown primary is patient is having some kind of a nodal mass, that is neck nodal mass. And head and neck surgical team, they must have evaluated in everything, everywhere. This is nasopharyngeal region, laryngopharyngeal region. There is no any tumor, but they will be having nodal mass. That is called as unknown primary. We don't know why it has, from where it has arises. That is called as unknown primary tumor. So usually in unknown primary, they go for either neck dissection. They may do neck dissection. After that, they may do concurrent chemoradiation, or they may do concurrent chemoradiation also. Treatment protocols may vary in different institutions. Okay, this gentleman underwent concurrent chemoradiation. Look at his fees examination. Before doing this examination, we performed the water solo test, and there was no any issues. And immediately after that, we removed the NG tube, And after that, we perform the fees evaluation. Look at this. Fantastic swallow. There's a little bit of edema in the larynx observed. Look at the lateral pharyngeal wall, right and left lateral pharyngeal wall. Very good contraction also happening. Look at the arytenoids. These are the arytenoids. Look at this one. See how well it is coming close together. Okay, it will protect the airway. There is no any aspiration. Fantastic, this movement. And definitely, sometimes we are going to fail in our rehabilitation. Sometimes it is very, very challenging to rehabilitate. This is one of our failure. Look at this, gentleman. It is the total glossectomy with pectoralis major myocutaneous flap. Okay, we gave just a small amount of thin barium. Look at this video fluoroscopy. So patient is struggling. There is laryngeal elevation is happening, but there is no any bolus propulsion, and definitely penetration is there. Multiple swallow is happening. Look at carefully. One point of time, he cannot hold his breath. He will aspirate. See, it is very, very challenging. Directly it is going, it is falling. Okay, it is reaching the valvula. These are very challenging to rehabilitate. Okay. Next. What is the main thing is team approach. Team approach is very, very essential in head and neck cancer management. We have to have a very good collaboration with the head and neck surgeon, head and neck radiation oncologist, radiologist, dietitian, then nursing staff. Everyone is essential, and with good partnership, definitely we will have a very good outcome, and our patients will recover very well, and we can give a very good quality of life for our patient. So in our protocol, I said sometimes it will be very challenging to do fees examination. Look at this image. This gentleman had a laryngeal carcinoma, and after a clinical evaluation, I scheduled this patient for fees examination. This was almost in 2017. I said schedule this patient. Then definitely after seeing that, I understood this patient is not a candidate for fees examination, because we cannot visualize anything, any larynx we cannot visualize. Look at the endolarynx, nothing can visualize. So such lesions, definitely video fluoroscopy is very, very essential. And look at this endoscopic image, has a severe secretion. It's almost, we use a New Zealand secretion scale. It comes almost with a 6 scoring out of 7. As severe secretion is there, and we performed a video fluoroscopy, and he had aspiration, severe aspiration. So it is not like that. Okay, we have to stop with the evaluation. Sometimes we may require both the evaluation. Okay, you have to be very mindful for the selection of the evaluation, and prior to the selection, we as a speech language therapist, we have to develop our skills and competencies in performing these evaluation as well. Look at this video fluoroscopy. It is a carcinoma of oropharynx post chemoradiation. This lady, she completed her radiation therapy, and she came with a complaint of a little bit difficult in swallowing. She cannot eat very well. Majorly, she is with soft food consistency, like minced moist only she is having. And after reviewing this video fluoroscopy, look at this video fluoroscopy again. What would be the cause of the problem? Look at here. There's a small narrowing is happening. This would be one of the reason. And there is no any weight loss. If it is persisting, if weight loss is there, then definitely we can intervene. And look at the AP view. See, there is a narrowing is there. This region, small narrowing is there. This is a short segment narrowing. Sometimes we may accept a long segment. That time patient symptoms may be more. So what is the take-home message in swallowing rehabilitation? We have to be very proactive. Speech and language therapists have to be very proactive. Proactive and intensive swallowing exercise regime is very essential. Baseline functional assessment, either prior surgery or prior organ preservation, is essential. Early recovery after surgery protocol we have to follow, as well as rehabilitation. Weekly follow-up during chemoradiation is essential. Collaboration with oncologist and medical team is must. Timely video fluoroscopy and fees is critical. And long-term survivorship evaluation also essential, because now in the present study since 20 years, we are understanding the long-term impact of head and neck cancer treatment. So maybe now the patient is very good after 1 year or 2 years. Sometimes he may come with a complaining of difficulty in swallowing because of fibrosis. Because radiation therapy, it has acute toxicities and even long-term toxicities. One of the long-term toxicities is dysphagia. So when the patient comes after 5 years or 6 years of treatment and he is complaining of difficulty in swallowing, we have to rule out two things. One, we have to rule out whether any disease has come again or the patient is having dysphagia. These two things is very, very critical in understanding and then proceeding further. So I would like to end now, and we can have some discussions. And if you have any questions, please do ask me. Or if you did not understand, if you're not understanding also, please do ask me. Okay.
Yes, sir. We have some questions for you. The first question is repeated saliva swallowing test used for head and neck cancer patients? Is it used in the screening test maybe? The clinical screening test?
Repeated saliva swallow test, yes, we can use. Okay. But what are we going to do next? We can use with the 4-finger test, like Professor Jerry Lockman said.
Okay, sir. We have another question.
Next thing, but we can use, just a minute, I have not completed, sorry. We can use and see how laryngeal movement is happening. Okay. And then when you are in a very initial career, these things and all will be helpful, and this will make you more competent as well. It will help you, but we cannot stop only with the repeated saliva test.
Thank you for the information, sir. The next question is, what are the management strategies we can use for total glossectomy?
See, management strategies for total glossectomy. First of all, we need to understand after surgery, total glossectomy, yes, the patient has undergone total glossectomy. We need to understand about the flap reconstruction. If it is pectoralis major mycocutaneous flap, definitely the outcome may not be that good. In all patients, we will not be a successful one. If it is a free flap, definitely the outcome. When we tell about outcome, it is not like 1 month or 2 months outcome. We have to think about 6 months long-term outcome, because total glossectomy is not a very easy rehabilitation. So even patient and caregiver have to be committed, and even we as a speech language therapist have to be committed to give the rehabilitation. So it is not a one day. Definitely everything, oral motor examination, we have to evaluate. We have to do the swallowing exercises and tracheostomy decannulation, whether it is possible or not. Okay, if you wish that he may be not a good candidate of tracheostomy, see how the secretion is happening. For understanding the secretion, definitely we have to do a flexible laryngoscopy to see the secretion, whether how he is managing the secretion. Based on that, step by step only, we have to go. At one point of time, definitely we have to do video fluoroscopy and see how the patient is performing. Without that, we will not be successful in this rehabilitation.
Thank you for the input, sir. We have another question. Could you please tell us about functional oral intake scale?
Yes, functional oral intake scale developed by Crary from Florida University in 2011 or 2012, and is a very standardized scale and has a very good psychometric properties. This scale, why are we going to use a scale? See, if I ask you draw a line, everyone will draw the line. If I ask you draw 5 centimeter line, everyone will take the our regular scale and measure, and they will do the sizing. So everyone comes uniform. So everyone lines are same because they are using some standard scale. So even a speech language therapist, we have to use a standard scale which has very good psychometric properties. That is the most important thing, so that we can measure our outcome. Like when we do our progress therapy report during our graduation period or post-graduation period, we used to write, okay, 2 months of speech therapy posting. So we must have seen in autistic children, yes, his behavior is good, his social behavior is improved. But when we take about improvement, how are you going to measure the improvement? If it is from 1 to 10, it has improved, or 1 to 5, it has improvement. So these things we have to keep in mind. It is not only in head and neck cancer, in every disorder we have to keep in mind. So functional oral intake scale is a scale where 7 indicates normal, 1 indicates patient is nil by mouth, the patient is having feeding tube, 1 to 3, the patient will be having feeding tube, and 2 and 3, 2 small amount he is taking along with the feeding tube, and 3 is majorly he is taking oral route along with he's having feeding tube. 4 means everything the patient is taking orally with only one consistency. 5 means the patient is taking everything oral intake, but he require special preparation at home, or even if he goes something, he has to use rice and dal in a very mashed manner. Okay, you're getting my point.
Yes, sir. Yes. So the next question is, what are the swallowing strategies or tools we can use with patients with trismus?
Trismus, we need to understand whether even before treatment, how much is the mouth opening. Okay, definitely mouth opening we can use. If you think about simple mouth opening, normal regular mouth opening exercises, like we have instructed the patient, we tell the patient to open his mouth and close his mouth regularly. Okay, maybe 10 repetitions each time, like 3 into 10 repetitions. That is one thing we can use. Other thing is we can use wooden spatula if mouth opening is less. Other thing is there is one instrument called as a terabyte. Usually Western countries, they use a terabyte. With that, there is going to be improvement. Or even in Indian make, there is called as a orabyte. When that also we can use as a therapeutic tool to improve the mouth opening. But remember, it's not just a mouth opening. Everywhere there will be problem. Those patients, these things, orabyte, terabyte, when we are going to use, there should have a very good this thing. Dentition should be very good. The teeth should be very good. If there is no teeth, they cannot use those instruments to do. So that we have to keep in mind.
Okay, sir. How do we treat GERD in TL patients as a medical SLP?
GERD in total
laryngectomy patients.
Some patients may have GERD. Okay, we, being a speech language therapist, only we cannot manage. We have to have a head and neck surgeon on board also for this management. We can we can explain about lifestyle strategies. and eating behavior. Apart from that, if anything is there, definitely head and neck surgical team only have to tell about GRD management.
Okay, sir. Tata, what is the type of NG tube you're using for head and neck cancer and oncology patients? The type of NG tube.
See, NG tube, usually NG tube is, we've used 14 French NG tube. NG tube comes with a various French, 12 French, 14 French, 16 French. But 14 French is, we usually use 14 French. Okay. And if you are suspecting for long duration, if you go to the Western literature, what is the requirement is, if there is a beyond 4 weeks of anticipation of a NG tube, they will go for PEG. Okay, but here we usually use NG tube only in majority of our patient. Exceptional patients such as total glossectomy, where we, even after a very good evaluation, their functional outcome is going to be very poor, we go for PEG. So 14 French NG tube.
Okay, sir. Thank you for the answer, sir. Should we do swallow strengthening and oromotor exercise during CTRT or wait for acute toxicities to subside?
It is a very, very good question. If you ask this question 25 years before, I will say that we have to give a treatment once the patient develops dysphagia. This answer will be available before 20 years. Now, it is not like that. We are knowing all these problems. We are experiencing these problems. Okay. So if you wait and watch after treatment, definitely the outcome is going to be very poor. Now, the current evidence is not like that. We have to do these exercises right before CTRT, during treatment, and post-treatment. And he has to continue long. You should not stop. That is the most essential thing. If you do, definitely you can have a very good success. That is a recommended protocol, not by even the team from Royal Marsden, and even the paper by Katie Hutchison, use it or lose it. This is one of the neuroplasticity which is applicable in head and neck cancer. If you are using it, definitely it is going to use it and improve it. That is another neuroplasticity that we can use it. If you are using it, definitely you can improve it. Otherwise, you are going to lose it. These two neuroplasticity we have to keep in mind in head and neck cancer treatment, and even before radiation treatment, we have to start the exercises, and during treatment, the patient have to do even post-treatment as well.
We have a couple of questions, sir.
Yeah, no problem.
Continue. Okay. At bedside, after swallow test, water swallow test, what intervention or therapy should we provide?
Just can you repeat the question again, please?
At bedside, after water swallow test, what intervention or therapy should we provide?
See, as I said, you guys, okay, only with water swallow test, how we are stopping? We have to categorize it is low risk, this thing, intermediate risk, and high risk. That is the most important thing. Only with the water swallow test. Please do not stop always. And look at this patient, general condition, and especially in strokes. We can expect silent aspiration risk. We cannot stop only with water swallow test. In head and neck cancer, maybe in follow-up, if there is no any symptoms, we can stop, but not with stroke or any other patients. Only with water swallow test, there is no any answer always. And if you have some experience, even that too anecdotal only, you may be competent. But only with water swallow test, not all the time we will be successful in answering those questions.
Yeah, the next question is, sir, in a lot of oral cancer patients, what are the other thin and thick liquid food items patients can have other than thin khichdi, dal water, and protein powder solution in Indian scenario?
Yes, when you take oral cancer, it can be a buccal mucosa, it can be a lower alveolus, anywhere can be, they may have to remove the bone also. So we have to see what surgery the patient has undergone. That is the most important thing. And look at the denture, the teeth. Sometimes patient will not be having any teeth because of the tumor. They have to remove the teeth. So those things we have to keep in mind. Okay, and after that only we have to say that whether the patient we can advance the food consistency. And in terms of food consistency, being a speech language therapist, I can recommend, okay, minced, moist, soft food, okay, he can take. And in that soft food, particularly what all things they have to use, that is a dietitian they have to do. Okay, so it is a team approach. That is again I'm emphasizing here.
Okay, so the next question is reliable test which we can use for swallowing assessment without instrumental evaluation.
See, ask yourself, one head and neck surgeon, sir, how are you going to operate without CT scan for this patient? Nobody will go without CT scan. Then the same answer is applicable for speech language therapist. Without instrumental evaluation, how are you going to do the intervention? Yes, I agree. If it is low risk, we can do. If it is intermediate risk, if it is high risk, that means we are working blindly, which it is not a very good practice. So we are not getting the roadmap. If you are having the success, that is your luck. If you are not having the success, then what are we going to do? Okay.
Sir, do we recommend any swallowing maneuvers for head and neck cancer patients? Which ones are the most beneficial?
Yes, definitely. We do recommend the maneuvers. Chin tuck is very, very effective. Supraglottic swallow, supraglottic swallow. Then head back postures. That is the head back postures is very essential, very, very useful. But remember, we have to see the maneuvers effectiveness also, how whether it is really helping or not. In that aspect also we have to do instrumental evaluation. We cannot say that blindly. Okay, if it is vocal cord palsy, definitely chin tuck is going to help. Okay, but how are you going to prove that it is helping for patients? So chin tuck is helpful, and supraglottic swallow, supraglottic swallow. Mendelssohn maneuver we can teach. If you have more time, definitely Mendelssohn maneuver you can teach. Okay.
So the next question is, the patient with post-radiation and partial glossectomy and restricted jaw movements, the patient presently is having a liquid diet and occasionally semi-solids. What is the best management option we can suggest?
This is a partial glossectomy, and we have to see how much is the mouth opening, how much mouth opening for this patient, 2 fingers or 3 fingers.
Rajalakshmi, can you unmute yourself and ask the question? Can you answer the query?
2 fingers, sir. 2 finger open.
Yeah, then we can continue the mouth opening exercises, and we have to see the tongue mobility also, tongue range of motion, how it is happening. Okay, and based on that we can see tongue range of motion is very, very essential, and what type of flap, whether flap they have done or not, in there is no any flap, that also we have to keep in mind. Okay, based on that we have to give our advice, and the patient have to continue the exercises regularly.
Okay.
Could you kindly elaborate on different flaps and their implications on the functional swallowing outcomes or therapy planning seen in your experience? To elaborate on different flaps and their implications on functional swallowing outcomes.
Yeah, if you take flap reconstruction, we can take oral cancer. For oral cancer, the flap they usually do is pectoralis major myocutaneous flap, anterolateral thigh flap. For bone reconstruction, they do free fibula bone reconstruction, free fibula osteocutaneous flap. Then even rectus abdominis flap. Then even free jejunum for total laryngectomy, they do free jejunum. Then anterolateral thigh flap. These are the major flaps. Okay, they will do submental flap in some like cases in small reconstruction. They do submental flap from this region. They do the reconstruction, and infrahyoid flap they can do. Sometimes they can take a flap from this region, that is called a forehead flap, but it has some disadvantage. Forehead flap, if they take, it will affect a lot of cosmesis. So usually they will not take the forehead flap, and they can take a chest flap, pectoralis major micropenis flap. Majorly for males they do. Okay, so irrespective of the flaps, definitely for tongue reconstruction, PMMC, for total glossectomy, near total glossectomy, the PMC flap may not be a very good option. Okay, but everyone are saying that okay, we don't have a fees, or we don't have video fluoroscopy in our hospital. Even surgical team also say that we don't have reconstructive team. That's why we are doing this one. So challenges are there existing everywhere. So we have to identify what are all the ways to develop the fees service and video fluoroscopy service. Every time, even in 2030, if you ask, we don't have fees or we don't have video fluoroscopy. But being a speech language therapist, what have you done till now? For example, if you are working in some hospital, you have to try hard. That is the only thing. Otherwise, then what are we going to tell our patient? Sorry, we don't have this service, we may have to go outside. So with that determination we need to have. We have to develop the service, means we have to develop the service. Okay.
Thank you, sir. One final question. Have you observed NGP syndrome in head and neck surgery and oncology patients? If yes, how are you managing it?
Can you explain that to NGT?
Kaibalia, the person who asked it, can you unmute yourself?
Hello.
Kaibalia, the person who has asked the question. Yeah. Could
NGT,
you elaborate on the NGT syndrome?
So NGT, you are talking about nasogastric tube or any other thing?
Yes, sir. It is nasogastric tube only.
Okay.
So nasogastric tube is it is not like it is acceptability what you are asking. Can you just ask like symptoms, what kind of patient is saying? Not willing
So
for the
mostly, like from my experience, what I have seen is if we are putting a Ryle's tube for a head and neck surgery patient, mostly after 1 or 2 weeks of this NGT insertion, patient used to complain about throat pain. Sometimes if we will do a fees, then we can see a unilateral vocal fold paralysis or bilateral vocal fold paralysis. And if patient can inhibit aspiration pneumonitis like condition, which is again fatal. So I just wanted to know how NGT syndrome is managed in Tata. I'm from Amrita Institute of Medical Sciences. So I just wanted to know what is the protocol in Tata. That's why I asked this question.
That's why earlier I said we 95% of the patient we will have NG tube only. We will not use PEG. Few patients they have a complaint about difficulty in keeping the NG tube. In such patients, we can think about having a PEG instead of NG tube.
No, sir. Sorry for asking again. Actually, I wanted to know, are you using a Ryle's tube? Like NGT, we have two types of NGT tube. One is Ryle's tube, which is not a feeding tube, and one is a Freca tube. So which tube you are using for the patients, head and neck surgery and cancer patients?
See, if you are using Freca tube, it is very good because it is very this thing. What I can say is flexible. Okay.
Yes, sir.
So Freca tube we use majorly for our thoracic surgery patients. In our head and neck, usually we use our regular nasogastric tube.
Okay.
That again, different institutions use differently. Freca actually it is good for long-term dysphagia. But if you take Western literature, even Australian guidelines, definitely beyond 4 weeks they go for PEG.
Yes,
But
sir.
in chemoradiation, those patients who are going for laryngeal cancer and hypopharyngeal cancer undergoing chemoradiation, now the things have changed. They go for only a majorly reactive feeding tube. That is, if there is a problem is there, then they go for nasogastric tube. Okay.
Yes, sir.
Yes.
Thank you so much, sir, for addressing our questions. Does any other participants want to unmute themselves for any other questions?
So I have one more question. Is EMG
Beautiful
biofeedback?
session we have got. Thank you so much for your inputs.
EMG biofeedback, definitely it will be useful, but we need to know how to perform EMG. That is one thing. I do not use EMG in our hospital. We do not use EMG, but we use FEES as a biofeedback, and even video fluoroscopy is a biofeedback. That will definitely helpful in patient to learn his swallowing task, such as supraglottic swallow. The patient has to hold his breath, okay, then swallow, then cough. These things will be very helpful in biofeedback. And even after the procedure, we always tell the patient to see his video fluoroscopy, or we can do feedback, like FEES based feedback therapy also we have done, majorly in partial laryngectomies also. See some other question.
Thank you so much, sir, for taking your time to address our questions. It was really a valuable session, sir. If any of the participants want to ask any questions to sir, can just unmute.
Thank you so much for everyone. Yeah,
I would
please.
like to ask. Yes, good evening, sir. Thank you. It was quite enlightening. Sir, I want to ask, apart about counseling, what you will suggest after the management to the patients to change in their lifestyle or anything else that they have to do, or any prevention precautions like some of the management? What will be the suggestions?
Management wise, we have to see how for example, after 1 year, the patient is coming, evaluate his functional aspect. It can be voice, quick. See, as I said, British Association of Head and Neck Oncology, what they have said two things: speech language therapy competency, FEES, and video fluoroscopy. These two tools are very, very essential in head and neck cancer management. That is one thing. The next thing is, you are doing integrity, voice integrity. You can use a GRBS, very quick scale. Okay.
Yes.
That is one thing. These small scales, these things will have a very good outcome in later. And then if the patient is doing well, ask the patient to do the swallowing exercises. And one of the important exercise we have to demonstrate for the patient is Shaker's exercise. That is the very, very effective exercise for hypopharyngeal cancer, laryngeal cancer, and even in oropharyngeal cancer also. When long-term outcome, patient is coming, suppose for example, if someone must have taken treatment some other hospital, and if he has come to meet you, you can demonstrate all the exercises. You can make the patient to do the Shaker's exercises, and you can recommend. We have to recommend these exercises to do at least 2 times a day into 10 repetitions. Okay.
Okay, sir.
Yes.
Okay, thank you, sir.
And make sure one thing I would like to think is, patients with neck dissection, that is majorly oral cancer patients, they will have a lot of difficulty in doing Shaker's exercises. In such scenario, you can think about using chin tuck against resistance, or you can ask someone, a caregiver, to support do the Shaker exercise. That is one thing we will modify. Otherwise, there is no any neck dissection has happened, they can do the Shaker exercise very well. Make sure that there is no cervical spondylitis and everything. Okay.
Yeah. Okay. Yes, sir. Thank you, sir.
Sir, myself, Soumya, sir. So I would like to know, with respect to if there's an infrahead flap or a PMMC flap for a carcinoma of buccal mucosa. So I would want to know if there will be any proprioception, or will the person feel if there's any bolus present in the side of flap. If yes or no, if it's no, how can we improve the proprioception, sir? Will massages help?
See, the proprioception is going to be less compared to how normal oral cavity tissues is there.
Okay, sir.
I have not worked on proprioception for any patient because they will get adapt to it very well. Okay. Definitely it is going to be less for every flap, not only infrahead flap or submental flap, whatever flap, the proprioception is going to be less. Because even we ourselves, we can experience, okay, hot water in our oral cavity, or if it is getting into our this thing, other skin. I have not worked on proprioceptive for any of our patients.
Okay,
So
sir.
I cannot comment more on this.
Okay. So will there be more of pocketing of food in case if you have not used any positioning technique with respect to flap?
Yeah, pocketing can
surgeries?
happen. Okay, for example, in buccal mucosa and even oral cancer, so the bowel of propulsion is not happening, the tongue mobility is less. Definitely that time pocketing we can expect. So one of the strategies is you can use liquid wash, you can use, okay, or slurp technique. As the patient do like this, it is called a slurp and swallow technique. You can tell the patient so that the pocketing will not happen, and he can slurp it and he can swallow it.
Okay, sir. Thank you, sir.
Sir, is there any schemes run by government for the patients with these kind of disorders?
Yeah, there are scheme. What are you asking exactly? You asked me.
Actually, sir, I want to ask about that. Wherever these treatments takes place for head and neck cancer, like in Tata Memorial Hospital, it will be quite cheaper and funded by Tata. So in outside, other than I want to know the situation outside the Tata, how they charge, the hospitals charge particularly, or there are some schemes by government. Like in our field, we have seen there are schemes by government for cochlear implants and many more things. So for these kind of patients, are there any schemes run by government?
Very good question. Okay, yes, schemes are available. One such scheme is called as Ayushman Bharat. That is one scheme. The next scheme called as PMJ funding. And Orissa government is having very good scheme. Even Bihar government is having their own scheme. Even recently Nagaland, they have come up with the scheme. Schemes are there. It is a very good question. Schemes are there. Otherwise, not all the patient can afford this kind of expensive treatment. And moreover, our head and neck cancer, if you see there many lower income group are getting affected because of habits such as having the betel nut, the tobacco, areca nut. Okay, so that is one of the major tasks. Okay, schemes are available. Definitely, that is getting implemented also in very good in like many hospitals. But in corporate hospitals, I do not know how much these schemes are being used. That is one thing. And they have to register, like even in corporate hospital also, they will be having some registrations. Okay, like they can take those patients. Okay.
Yes, sir. Thank you very much.
But especially one thing is where challenge we are going to face in head and neck cancer is total laryngectomy rehabilitation, voice processor, electrolarynx. The funding for that, even chief minister funding also is there. So that is one thing. And funding for voice processor electrolarynx is a little challenging. Okay, in our hospital, we are trying our best to do for many of our patients. Almost 80% will get funding for either voice processor or electrolarynx, and even for suppose nutritional support as well. Okay, but I do not know how much it is happening in other center. I cannot comment on it. So that is one of the disadvantage. Okay.
Okay. Thank you, sir.
Thank you so much, sir, for taking your time, actually exceeding your time, and answering all our queries. Thank you for addressing the inquisitive minds. Thank you, sir. Over to Priya, ma'am.
Yeah, I invite Mrs. Susan ma'am to give the vote of thanks.
So good evening all. So on behalf of the Department of Speech Language Pathology, Helen Keller's Institute, I would like to propose the vote of thanks. First of all, I would like to thank our resource person for today, Mr. Arun Balaji, for accepting our invitation and taking time out of his busy schedule. And he just came from his hospital. We couldn't have got a better resource person today than him. So thank you, Arun, for your excellent presentation, which was really enriching and informative. I'm sure all the participants, it is useful for all the participants. Thank you, Arun.